Infection Control, Introduction to Nursing Concepts. This is Martha Olson. As we look at our infection control, we know that nurses are responsible for providing quality care that incorporates infection control principles. It's not just a hospitalized nurse or the nurse that works in long-term care. This is every nurse that's worrying about infection control. Many facilities have an infection control nurse that monitors the new policies, that monitors the infections within that facility, and they are also responsible for making sure that education is taking place and they are monitoring infection rates, because that is reportable to the state and many other departments. When we look at why all hospitalized clients, what they have in common, it's at risk for infection. When you walk into a hospital, other patients have infections, your caregivers might not have good hand washing, or there's infection that is going throughout that. As we look at our principles of infection control, the increased cost is concerning because Medicare is now saying we will not pay for infections that are acquired when they are hospitalized. So if you put a catheter in, an indwelling catheter, and it is not done correctly and they get a urinary tract infection, the hospital has to contain the cost of that. And so if the patient is on antibiotics, if they have to stay in the hospital longer, the hospital has to pay for that. Insurance is not going to cover that anymore, and that's been a big change in the last 5 years. That occupational exposure, when I go to work, I might have somebody with a really bad cough and we find out later they were diagnosed with tuberculosis. So knowing infection control, when somebody has a cough, I automatically put the infection control procedures into play until they're ruled out from having something else. You always treat a patient like if they potentially could have it, put them in a private room, put them in a mask, make sure that you're following the procedures until it's ruled out differently. We also know there is more methicillin resistance and vancomycin resistance, those resistant microorganisms out there that are causing us to not be able to use some of the standard antibiotics that have worked in the past. 76 trillion is a number of bacteria in which one bacterium can generate within 24 hours. Bacteria in our body can be good. Some lives on our skin, some in our colon, but for the most part, when we think about infections, it's either a virus or bacteria causing that. These are reportable, communicable diseases to the state of Iowa. Your infection control nurse within that facility has the responsibility to report those so that they can be tracked, and the state is keeping an eye on all of those. We know that virulence, or the ability to survive in the host, is one of the principal infecting agents. We need to think about how did it get into or enter and survive within that host, and then what is the susceptibility of that host or the host resistance that we see. Colonization is the microorganisms are present, but it doesn't really come out as a disease or infection. I'm probably colonized in my nares, and that's because I work around healthcare. I've been in it a long time, but I'm not ill. Infection is when somebody is ill, it alters normal tissue function. When you have a patient come from long-term care, many of the hospitals are doing a swabbing of the nares to see if that person is positive for MRSA. We swab the wounds and we look to see, do they have that MRSA in there, and then we can put them on a higher level of precautions to help control the spread of that infection. When we look at the nature of infection, we'll be talking about that chain of infection and how we can work on breaking that chain in all of the steps. The course of infection, our body's defense mechanisms, and then also those nosocomial infections that we see. All listed in this chapter in our reading for this unit. Our infectious agents, or our chain of infection, is starting out with what is the agent? How virulent or strong is that infectious agent? We know it depends on the number of organisms present and can they survive. Your reservoir is where those microorganisms like to live and multiply, and they wait for that time when they can transfer to a susceptible host. Maybe it's on the bedside table, maybe it's the doorknob that never got washed. So, where is that microorganism sitting, waiting to be to find somebody that is very run down and susceptible. We know that it can be in food, it can be in water, other human beings, animals can be carriers of that. Pseudomonas survives in nebulizer treatments, so when you have a nebulizer equipment and it doesn't get cleaned properly, it's warm and moist in there, and bacteria like those types of places. We think of wet summers here in Iowa where that reservoir is standing water and puddles of water where our mosquitoes can breed. And we tend to have a lot of mosquito problems in summers where it's very moist. Our portal of exit is how it gets out. They can exit through a variety of sites such as skin, mucous membranes, the respiratory tract with coughing and sneezing, the urinary tract, GI tract with fecal matter, the reproductive tract, and our blood. And when we think about, when do we wear gloves, we think about that portal of exit, when somebody vomits, when somebody urinates, when we are helping somebody, with changing their colostomy or emptying the colostomy. We wear gloves at all of those times because of that portal of exit, and we want to break that chain. Our mode of transmission is how you get there. And it is looking at many different things. That major route of transmission in the hospital is unwashed hands. Hands that are taking bacteria from one site to another, one patient to another, one source to another. Portal of entry is that patient that's had surgery and they have an opening or a wound. Any body orifice is a portal of entry. The eyes, the nose, the mouth, the vagina, the rectum, all of those are portal of entry sites for the organisms. And then that susceptible host is very individualized. What is the nutritional state of that person? How run down are they? Do they have enough white blood cells and T4 cells to help them keep those bacteria at bay or to take care of them? When we think about the patient that is highly susceptible, it's your HIV, your cancer patient, people that are malnourished, the elderly, the very young. Those are our very susceptible populations or vulnerable populations. So here is just a diagram of that chain of infection, and we think of what do we in healthcare do at each step to try to prevent the spread of any infections. In looking at our precautions, we know that droplet mode, where we can see the woman sneezing with a common cold, that's covering. That is either covering with a tissue or coughing into your sleeve. When we look at good hand washing, when we look at water, vector-borne, that's the mosquito or the tick. That is people with the bullseye rash from Lyme disease. So there are a lot of different examples that we could use here. The course of infection has different terms. Potter and Perry uses some different terms for that. We'll go off of what is in Potter and Perry in your reading textbook. That incubation period, or that pre-exposure, when the pathogen first starts showing symptoms. These are people that come to school and come to work. They just don't feel good, they're a little run down, but it's not bad enough that it's going to keep me home. The preclinical or prodromal stage then is where they have those non-specific signs and symptoms. And in these early stages, we know that people are very susceptible. I got the chicken pox from my cousin at Thanksgiving one year when I was in 6th grade. When I was there, she had no symptoms. And by the time we got back home to Iowa, and my Aunt Donna called and said, Leslie has the chicken pox, I got the chicken pox, and everybody in Armstrong that winter had the chicken pox because I brought them home. When we look at the clinical stage or that illness stage, that's when you know you're sick and you stay home and you've got the chicken pox outbreak and you've got the fever and you're nauseated. And convalescence is where the symptoms are disappearing, and oftentimes that's where people rush back to work or back to school. They don't take enough time to really get over that, get their immune system built up. And it seems like when people don't take the time to get stronger before coming back to their usual routine, they then catch another illness and they get sick again, and it takes them longer to get over it because that length of resolution is going to depend on how severely ill they were and also how they take care of themselves afterwards. The body's defense mechanisms is looking at things like our normal flora. We have microorganisms that reside on the layers of the skin. Our saliva is a normal flora, as well as the intestinal wall. our body defense mechanisms is looking at things like our immune system that help keep us strong, and we have that the memory cells that say, hey, you know, you've had chicken pox before, we're not going to have that again. So it's getting into some of the inflammation and immunity units that we study in pathophysiology for that. With inflammation, we know it's a protective reaction to help neutralize pathogens, and so the vascular reaction is protective, and it brings fluid and blood products and nutrients to that site of injury or to the place where this is happening, trying to help stabilize and get that person over it. And then when we look at our immune response, again, our very young and older, very vulnerable. Our patients that are sick or run down with other pre-existing conditions are very vulnerable during that time. As we look at vascular and cellular responses, I talk quite a bit about that when I teach pathophysiology. Obviously, we're going to talk about some of the cellular responses. The neutrophils are the first ones to the response or to respond to that infection. The neutrophils come quickly, but they don't have a long half-life. They aren't able to maintain that degree of help for very long, and that's where some of our slower macrophages come in, and they take over then, and they have a longer ability because they aren't as highly reactive. You know, they show up and they hang in there until that person gets well. Vascular is a vasodilation, bringing more blood flow as these cells start deciding to come in and come to the rescue. The vessels get bigger, kind of like when there's a fire and they clear traffic off the road so the fire trucks can get to the scene of the accident. Well, the first ones to the scene are the neutrophils, and then slowly comes in the macrophages and some of the other cells that help with that. Looking at normal flora, it does not cause a disease. It actually helps maintain health. And we know that normal flora, such as the acid in the stomach, the thick secretions in the lungs that trap bacteria, are those things in the body that help defend against infections that we have. Any factor that disrupts that places a person at risk for an infection. So if I take a lot of antacids, and there's a very nice diagram in your book that looks at some of these things. If I take antacids, I don't have the acidic stomach that's going to kill the bacteria in the food that I eat. If I have, let's see, what's another example? A broad spectrum antibiotic. It kills the normal bacteria in my colon, and a lot of your patients will wind up with diarrhea because they have lost that good bacteria in the colon that they should have. So when we think about why this is such a big deal, we don't want to overuse antibiotics. We want to save them for when the body really needs them for bacterial infections. If you go into the doctor and you have a viral infection and you ask for an antibiotic, soon your body will build up a resistance because it'll say, I've seen that antibiotic before and it doesn't really matter. So then the next time you have to use a bigger and stronger and different type of antibiotic to take care of that. That's why we have to be very careful about using and overusing antibiotics, because people can get these super infections that can cause us a lot of problems down the line. So in looking at why this is a big deal, we had a lot of different strains of resistant bacteria. Many of them are very common in this area, and we are seeing them in our patients in the hospital and in long-term care, as well as public health. So as we look at these, to wrap up this first part of our infection control, we know that MRSA is an organism that's resistant to the penicillin family, and VRE is vancomycin, and that really nice antibiotic called vancomycin is no longer effective in those patients that are resistant to that. So these are just a couple of examples of overuse. In our next unit, we're going to look at what is a nosocomial infection, what causes it, and what we can do to help prevent that as healthcare providers. So I'll see you in part 2. Thank you.